Um, Continuing on, I just wanted to convey my excitement, and it is my pleasure to introduce our next guest speaker in the Collaborative Light series of medic speakers, Dr. Todd Florin. Dr. Todd Florin is an associate professor of pediatrics in the Division of Pediatric Emergency Medicine at Lurie Children's Hospital, Chicago. This is with Northwestern University Feinberg School of Medicine. Dr. Florin serves as the Director of Research for the Division of Emergency Medicine at Lurie, and he's also the head of the Granger Initiative for Pediatric Emergency Medicine Research. He's a nationally recognized expert in the field of respiratory infectious diseases in the acute care setting. He is the past recipient of the Academic Pediatric Association Young Investigator Award and has received numerous research awards from Lurie Children's, the American Academy of Pediatric Sections on Emergency Medicine, as well as Hospital Medicine, and mentorship awards from Cincinnati Children's Hospital. He currently sits on the Executive Council for the Society of Pediatric Research, one of the highest bodies of pediatric research in the United States. Dr. Florin's research program aims to improve the diagnosis and management and outcomes of children with common serious infections and focuses on lower respiratory tract infections, much aligned with medics' work. His recent work centers on development of risk stratification tools, use of biomarkers to improve outcomes in children with pneumonia at the point of care. He also has published in resource utilization, variation in care, antimicrobial stewardship, and use of clinical trials to improve treatments for respiratory tract infections in children. Please welcome Dr. Florin. Todd, great to see you. I hope you can help us shed some light on our utilization issues in medic.
Thanks, Michelle, for that really kind introduction. It's great to be here, and thank you to Michelle Nypaver, Michelle Macy, Keith Coker, and the other folks at the medic team for this invitation to speak with you today about this topic that is near and dear to my heart. I'm going to share my screen here and hopefully all will go well. We're looking good? Okay, so today we're going to talk about what's the big deal. It's only a chest x-ray, and I know that medic is doing a lot of work in this area, and I hope that I'm likely telling you a lot of things that you know and have heard already. I'm hoping that you can pull away from this talk a couple of new things as well. I'm going to frame today's discussion as in 4 parts. The first is the challenge that we face in diagnosing kids with lower respiratory tract infections. The second is a summary of some of the key evidence in this space. We'll then move on to implementing the evidence and QI and implementation science initiatives that other institutions and investigators have taken to try to integrate some of this evidence into practice. And then I think we'll end with some opportunities, and I look forward to some questions and answers during the last part of this talk, because ultimately I would love to hear from you in terms of what you've done. As a disclaimer, I've learned a lot of what medic is doing in this space from Michelle, Keith, and others. Inevitably, I am likely to make some mistakes, so please feel free to correct me in the chat if I get something wrong, or share something new if there's something that I don't know, because I certainly don't know all of the details. So let's hop in with the first part of this talk, which is really the challenge, and how do we know which kids that we see in the acute care setting require chest radiography. So this is a typical November day. We have an 18-month-old boy, comes into the ED, no past medical history, full term, immunizations are current, including for COVID, has had 2 days of cough, upper respiratory symptoms, fever, and in the ED, temperature is 38.6, heart rate's 133, respiratory rate is 44, saturation is bordering on hypoxemic at 94% and room air. There's clear congestion, diffuse rhonchi when you auscultate, mild dyspnea, retractions, but no clear, wheezing. There's not monophonic wheezing, no clear ralls, no grunting, no flaring, and generally it's well perfused with a capillary refill of less than 2 seconds. So I think this probably describes about 80% of the children that we all see, in the emergency department. And a typical winter, or if it's COVID, maybe it's a typical fall, but we're all familiar with this case. And what we all start to think when we see a child like this is, what's the diagnosis? Could this be the beginnings of asthma? Could it be bacterial pneumonia, viral pneumonia, atypical pneumonia, or is this just viral, wheezing, bronchiolitis? And of course, all of these things have different treatment pathways. So I think making the diagnosis is critical in terms of, diagnostic accuracy to promote therapeutic reliability, so that if it is asthma, we're treating it appropriately, and we're not giving kids who will not benefit from bronchodilators or corticosteroids those treatments. The diagnostic challenge is that all of these diagnoses overlap. And so it becomes very hard for clinicians, based on Gestalt alone or the overall clinical presentation, to be able to differentiate, between these different diagnoses, each of which requires a different therapeutic approach. So I really became keen to this back when I was a fellow during my master's degree in epi. And I did this study using the Pediatric Health Information System. Many of you may be familiar with this, PHIS, where we looked at resource utilization in diagnostic testing in the emergency department for kids with an ultimate diagnosis of pneumonia. And what we hypothesized was that, there will be variation clearly, but that higher utilizing hospitals will have higher hospitalization rates, and lower utilizing hospitals will have higher revisit rates, because in theory, they will be missing things by not using as many tests. And we were actually proven a little bit wrong in at least the latter hypothesis. So here in graph A, you can see that as utilization increases, hospitalization increases nearly twofold. However, when we looked at revisit rates were pretty steady, regardless of whether your utilization tertile was low, moderate, or high. And in this heat map, which we generated, you can see chest X-ray highlighted here in the olive green color. You see the great degree of variation that exists across these 36 hospitals. And not surprisingly, the message here is if you are a high utilizer of one type of test, you are a high utilizer of all the types of tests. So let's go to the radiograph for this patient, that I presented. And here it is. And, if I were to look at this, and I know we don't have fancy packs here, and I can't, play with the magnification or the contrast. But if I were to look at this, I would say that I see lungs that have increased peribronchial thickening, some increased hilar adenopathy here. You can definitely see there's your peribronchial thickening, some increased interstitial markings. But, if you look at the heart borders and the diaphragms, the borders are pretty clear. There's no effusion there, and there's no real frank consolidation. So that would be my read of this film. I would venture to guess that maybe 60% of you agree based off of the literature on the reliability of chest X-rays. But ultimately, this was the actual read of this chest X-ray. Bilateral perihilar opacities and central peribronchial cuffing, non-specific, though can be seen in the setting of viral illness or reactive small airways disease. There are some hazy airspace opacities noted over the left lingula, left lower lung, which may reflect developing superimposed pneumonia in the appropriate clinical setting versus atelectasis. So, in this read, I'll let you go back and see if you can find the slightly hazy opacities that the radiologist was referring to. But we are provided with this clinical read, in this context, and are left with basically three diagnoses that come, that we had discussed initially that come out of this read. And I think it puts us as clinicians in a bit of a tough spot when the radiologist is reading this. And I think a lot of us may be quick to blame the radiologist. We've all made jokes about, clinical context required. But in reality, the radiologist does not have an easy job here. And because they're given a test that is really imperfect, especially in younger kids, and that, in the chest X-ray. And what you see here, this was a study that one of my mentees did way back in 2013. Dr. Test is now a pediatrician. I think he's in Seattle. And he looked at the inter-rater reliability of different radiographic findings based off of 6 different pediatric radiologists who were reading these films. And this study was meant to see, does the clinical history actually alter the radiologist's impression of the film. And in most cases, the answer is no. In some cases, it's yes. But the main message that I wanted to pull from this slide was that the inter-rater reliability for any infiltrator on a chest X-ray is pretty poor, 0.47. And that's radiologists, pediatric radiologists. Now, if there's a clear alveolar infiltrate, they do a pretty good job. But I think for every other finding that you consider, on these chest radiographs, the inter-rater reliability is not great. And I think with that, and therefore, I don't think we can completely blame the radiologists when we get reads like that, because they're given almost an impossible job at that point. And I think this is where the clinical context of what we do really does matter. So what's the big deal, right? We have this 18-month-old with fever and cough. In this case, the physician obtained a chest X-ray that you saw the read. Basically, it's atelectasis versus infiltrate. You can't really rule it out, right? So most clinicians, and we know this based off of looking at data, treat these sorts of equivocal chest X-rays with antibiotics. And so in this case, this child who likely had a viral illness was given amoxicillin largely as a result of that chest X-ray read. This child came back in 2 days, still with a fever and a cough. And so the clinician who saw him on the second visit said, okay, well, the fever's persisting despite amoxicillin, still coughing. So I'm going to ramp up my therapy a little bit, broaden my spectrum a bit. Let's give this child amoxicillin clavulanate. So this child switched antibiotics 2 days in, and then came back to 2 days later, now with a rash and still coughing. So the concern was, okay, maybe this is an allergy to, amoxicillin, a penicillin allergy. I'm going to now switch to another broad spectrum antibiotic, ceftonir. Well, then a day later, this family was not warned about what ceftonir can do to your poop. And a day later comes back with still coughing, still not looking great, and now with bloody diarrhea. On the third visit, the clinician says, well, this is your third visit, I better do some labs, and gets a CBC and the white count is 20,000. At that point, the clinician says, okay, well, 38-hour visit, still coughing, still with symptoms, a white count, borderline high. I think I need to admit this kid for IV antibiotics. And ultimately, I think that all of us have seen some permutation of this situation, and it's left all of us feeling like this. This is a very frustrating situation. And I think what this situation encompasses is what Moldenstein called the cascade effect in the clinical care of patients. And this was a commentary that is one of my favorite commentaries in the medical literature. It was written in 1986. I won't tell you all how old I was when this commentary was written, but essentially it discusses the exact same thing that happened to our 18-month-old patient. This is the cascade of clinical testing that happens. And so Michelle Nypaver called this in a previous discussion, what's the collateral damage of low-value chest X-ray use? And I like that term. And I think the major concern with doing chest X-rays, which is such a simple test for us to just order and get, we put the order in, we go see the next patient. By the time that we're done seeing the next few patients, that X-ray's back and we can make a treatment decision and send that child on their way. Well, the collateral damage is that most importantly, inappropriate antibiotic use. And I think for those of you who have kids who have gotten antibiotics, even our basic bubblegum amoxicillin, we can see diarrhea, we can see stomach upset from that. These kids can oftentimes get rash. We've all seen it. Penicillin allergy mislabeling is a major problem right now. And most kids who are labeled with an allergy to penicillin do not actually have a true allergy to penicillin. And as a result, they are now getting broader spectrum antibiotics that they don't actually need. We do know that antibiotics are the leading cause of subsequent ED visits for adverse drug reactions for kids. And so additional ED visits can occur as a result of inappropriate antibiotic use. Rarely C. diff colitis occurs. It's rare, but when it does occur, it's severe and fatal, can be fatal. Clearly, antimicrobial resistance, this has been spoken about for years. President Obama declared this a global public health threat, and it still continues to be something that we worry about. And now, as our diagnostic techniques and our laboratory techniques become more elegant and sophisticated, we are starting to see the effects on the microbiome that even a single course of antibiotics can have early in life, and having some short and longer term effects from inappropriate antibiotic use. So this idea of, well, it's just a chest x-ray, what's the big deal? That cascades to, well, it's just amoxicillin, what's the big deal? And then eventually there's all these issues. And I think all of us have been feeling this acutely. This is from the New York Times. We've all felt this, November of last year. The headline is flu and I think the headline is kind of hysterical actually, but flu and RSV hit the holidays, heightening demand for antibiotics. So we should not be giving antibiotics at all, but why are kids with flu and RSV getting antibiotics? Well, because they're getting chest x-rays and you're seeing schmutz on the chest x-ray, and then they're getting antibiotics, and now we have supply problems. And now we've got kids who need narrow spectrum antibiotics for their bacterial infections, but now are having to be given broad spectrum antibiotics because we're overusing our narrow spectrum antibiotics, leading to shortages. You get the idea. I could go on and on, but I think you get the idea. I think other collateral damages from chest x-ray use include misdiagnosis. This comes up. They are told that they have pneumonia. We see kids whose parents say, oh yeah, they've had pneumonia twice, 3 times in the past. If you've had pneumonia 3 times in the past, you probably have an immune deficiency. So it's not, recurrent pneumonia is actually not a common thing, but if we're misdiagnosing pneumonia, then we are increasing parental anxiety, and ultimately that misdiagnosis is going to have an effect on how that child is treated subsequently at future healthcare visits. More testing, we talked about this, going further down that testing cascade. Radiation exposure, cost, and time are other collateral damages of this low-value chest x-ray use. So now that I've framed the problem, let's talk about some of the evidence. What do we know about which patients require chest radiography? So this was a study that Bonnie Matthews did while she was a fellow at Boston Children's Hospital. She's now at UMass, and she did this work with Mark Newman at Boston Children's. And they looked at 526 children, median age of about 2 years. So most of these kids were really young wheezers, either bronchiolitis or viral wheezers. And they looked for predictors of pneumonia among wheezing children. And 47% of the 526 children had a history of wheezing. And the bottom line is that pneumonia was pretty uncommon. I won't say it's rare, but it's pretty uncommon. 4.9% of the whole study cohort had pneumonia on X-ray, 26 kids out of 526. And only 2.2% among afebrile children. So here are the factors that were associated with predicting pneumonia among wheezing children in that study. So a history of fever, a history of abdominal pain, higher temperature, and lower oxygen saturation. And I think this is one point that you'll see over and over in the evidence that I'm going to show you, is that, fever, higher fever and lower oxygen saturation, hypoxemia, are going to be 2 of your key sort of drivers to think about, is there pneumonia going on in this child who's wheezing or presenting, in respiratory distress. If they don't have a fever, and if they're not hypoxemic, it's pretty unlikely that they are going to have a bacterial pneumonia. And so just something to keep in mind. Now, this was a pretty small study. It was 500 kids. We wanted to sort of replicate this and really look specifically within kids who had an asthma diagnosis. What were the factors that were associated with pneumonia? And this is work that Hannah Karen did during a summer research internship with me. And she's now a fellow at Cincinnati Children's in pediatric emergency medicine. She's doing outstanding work there. And we looked at 14,000 ED visits for asthma, for an asthma exacerbation. And in those that 14,000 ED visits, 1/3 had a chest x-ray performed. That's a lot of x-rays performed for asthma. And of that cohort, only 280 or 5.9% of the total cohort, 5.9% of the kids with chest x-ray performed, about 2% of the whole cohort had a radiographic pneumonia. So again, pretty uncommon. And so we looked in multivariable regression analyses to try to uncover what factors were associated with pneumonia in kids who presented with an asthma exacerbation. I still don't understand the biological underpinning of female sex and how that ended up in the model. So I can't help with that. But what I will draw your attention to is that, again, fever and significant hypoxemia, less than 90%, were generally together associated with increased odds. And actually in kids with asthma, when you look at the older kids, so the younger kids are even more likely to just have viral schmutz. But I think if you're looking at an older kid who is significantly hypoxemic and has fever, the odds ratio in our study was almost 6 times the odds of having a radiographic pneumonia if you had all 3 of those factors. So again, just thinking about that fever hypoxemia theme, that's come out pretty consistently in our work. So what about in bronchiolitis? This is a great study that Suzanne Shu and colleagues in Toronto, sick kids, published in 2007. And what they did was they looked at 265 kids who had chest x-rays performed, who presented to the emergency department with classic symptoms of bronchiolitis. There was nothing really unusual. These were the kids that were under, I think, 12 months of age and who had really classic bronchiolitis. And of 265 radiographs performed, only 2 were not consistent with bronchiolitis, so had some other finding that would lead the clinician to another diagnosis, pneumonia or otherwise, which means that you need to x-ray 133 children with classic bronchiolitis to find 1 x-ray that is inconsistent. And what Suzanne and colleagues found was that the risk of airspace disease, so pneumonic consolidation, was particularly low in kids who only had mild to moderate respiratory distress and whose saturations were greater than 92%. Again, our oxygen saturation comes into play here. So despite the fact that all of these kids, nearly, save for 2, had x-rays consistent with bronchiolitis, here's the collateral damage. More than 5 times as many kids received antibiotic therapy after the radiograph as compared with their pre-radiograph intended management. So the x-ray didn't change the diagnosis, but more than 5 times the as many children got antibiotics. So again, clinical cascade that we're seeing here. So just as an aside, well, people say, well, I'm worried about, you can have a normal chest x-ray and then develop pneumonia. And that is the dogma that I think we all learned in medical school, and it's not impossible. It can happen. But I really like this study that Dr. Lipset, Susan Lipset, and Mark Newman performed in Boston Children's that was published in 2018, that essentially looked at what is the negative predictive value of a chest x-ray. You have a negative x-ray, normal x-ray, who's coming back? So they had 497 negative x-rays in this cohort, and 91% of these were not diagnosed with pneumonia clinically. So they did not have a clinical diagnosis, and they did not have a radiographic diagnosis. And of those, 90% were not treated with antibiotics. So of those with negative x-rays, no clinical diagnosis, no antibiotics, only 1.2% were diagnosed with a pneumonia within 2 weeks of an ED visit. So the negative predictive value in this study is 98.8% with a tight confidence interval of 97 to 99.6%. And I think what Dr. Lipset's work shows us is that we can be pretty reassured that if we're seeing a negative chest x-ray, we can trust the negative chest x-ray. So this study that I wanted to share was, well, does chest x-ray actually make a difference in the outcomes, in the time to recovery because of what you see in the chest x-ray? And George Swingler and colleagues did this study that was published in Lancet. This was done in Africa. And they randomized kids to getting a chest x-ray versus not getting a chest x-ray. And these are kids that had a clinical diagnosis of pneumonia, 522 kids, 2 to 59 months of age who met WHO definition for pneumonia. And the median time to recovery was 7 days in both groups. And you can see from this Kaplan-Meier curve that essentially the groups looked identical in their time to recovery. And this lack of effect, it was not modified by the clinician's experience. None of the subgroups that they looked at with a chest X-ray had an effect. However, what you see in this table is that antibiotic use, particularly for the quote unquote non-specific lower respiratory infection, was much higher in the chest X-ray group compared to the non-chest X-ray group. And the chest X-ray group, whether they received one or not, it didn't affect the clinical outcomes. There were no differences in revisits, admissions, or subsequent need for chest radiographs within 28 days. So here's another example of, if you get the chest X-ray, you're going to get unnecessary antibiotics, but really there were no difference in the kids that were diagnosed clinically or the kids that got a radiograph in this study. So we became very interested in this idea of, what is happening for these kids with non-radiographic pneumonia. And so what we did was, this was led by Jillian Cotter. Dr. Cotter is a hospitalist at Colorado Children's, just submitted her K-23. We've got our fingers crossed for her on that. Used our cohort of kids, 477 kids, 3 months to 18 years of age, who had clinically suspected pneumonia. They came to the ED and the clinician was suspected of pneumonia and ordered an X-ray to confirm. And in this cohort of 477 kids, 140 or 29% had radiographic pneumonia. 105 had equivocal pneumonia, 15% had atelectasis, and 34% had no atelectasis or consolidation. And so non-radiographic pneumonia really is this group at the bottom, this bottom three. And when we looked at, in multivariable analyses, at what were the factors associated with getting inpatient antibiotic use, we found that age, history of fever at home, receipt of antibiotics in the ED, and receipt of supplemental oxygen made these kids who did not have radiographic pneumonia on X-ray, but had clinically suspected pneumonia, receive antibiotics and have those antibiotics be continued in the inpatient setting after the ED visit. Now, importantly, and I think this is important for all of us, again, collateral damage. The strongest factor associated with receipt of antibiotics in the inpatient setting for kids with non-radiographic pneumonia was receipt of antibiotics in the ED, right? And this is a concept I think we've all heard about. It's called therapeutic momentum. Once one doctor starts something, there's a little bit of a hesitancy to stop it. And so in this case, we did find that there was a therapeutic momentum challenge. When the ED docs started antibiotics, the inpatient docs were not stopping them, even though there was not a clear pneumonia on X-ray. And what we also looked at was the interaction between antibiotic use in the ED and the actual findings on chest X-ray. And what you can appreciate is that in most cases, there was significantly elevated risk of receiving inpatient antibiotics across radiographic findings with no atelectasis and no pneumonia as the reference group in this. So of the 232 kids with non-radiographic CAP in our study, 29% received inpatient antibiotics and 21% received a full course of antibiotics, was not stopped. And they represented 24% of all kids given inpatient antibiotics. And most who received antibiotics in the ED and had antibiotics continued had those completed for a full course. So some of our next questions were around, well, okay, there's a problem here. These kids are getting a lot of antibiotics, chest X-ray doesn't change outcomes, but you still are worried about, well, which kids do we need to X-ray? And so Dr. Sriram Ramgopal, who is an assistant professor with us at Lurie Children's, became interested in this question and developed a prediction model for pediatric radiographic pneumonia. And we developed two models. One was a full model that included about 25 different factors. And in that full model, increasing age, prolonged fever duration, tachypnea, and focal decreased breath sounds were positively associated with pneumonia, and the presence of rhinorrhea and wheezing were negatively associated with pneumonia. Now, what we tried to do was we used backwards stepwise selection to try to create a more parsimonious, simpler model. And we called that the reduced model, which included increasing age, increasing days of fever, and focally decreased breath sounds, just 3 factors. And you can see the discrimination, which is the ability of the model to discriminate those who did and did not have pneumonia. The light line is the full model, which had an area under the curve of 0.85, and the dark line was this reduced model, which had slightly decreased performance as you would expect, but not by all that much. And then when you look at calibration, which is the observed versus expected, when you put these kids into predicted bins, we divided it into tenths, deciles. And you can see that if the model gave you a low predicted risk, most kids did not have pneumonia. So we felt that we developed a model that was discriminated fairly well and calibrated well. Now, for a heterogeneous condition, you're sometimes used to looking at these area under at these ROC curves and expecting, an area under the curve of 0.95. For a heterogeneous condition like LRTI, that's never, ever going to happen. So I think anything that's above 0.8 and you combine that with clinician judgment, you're thinking about something that's pretty good. And when we looked at these deciles of risk, we found that they naturally sort of put together a sort of low risk group, an intermediate risk group, and a high risk group. So you can see in the low risk group, you had a very low negative likelihood ratio. It represented about 25% of the population, and you had a sensitivity of 95% if your risk threshold was 6% or less by our rule. And similarly, if your risk threshold was 37 or greater, and this represented about 20% of the population, here you see your likelihood ratio positive surpasses 5, changing your pre to post test probability moderately, then you likely don't need the X-ray in this group. You can just go ahead and treat them. Now, this intermediate group is actually one group where the X-ray may help you to avoid, if you have a negative X-ray, then you could avoid giving antibiotics in this intermediate risk group. So we also did work to then validate some of the existing rules that exist in the literature. And Mark Newman published one. It had a lot of variables. It makes it a little unwieldy. Rihanna Oostenbrink in the Netherlands published a rule, but one that included CRP, which we generally do not get in most, we don't have point of care CRP in the US. And then Dr. Lipset with Dr. Newman published a rule in 2021 that had, again, triage oxygen saturation, fever in the ED, RALS, and wheeze. And what we found when we validated is that these 3 rules generally validated pretty well. We externally validated these rules on our prospectively collected data set of 1,140 kids and found that they performed well as well. So I think the next steps for all these rules is to really firmly externally validate them and then start to look at if we can implement them into practice and if they have an impact on clinical outcomes. So I would say that these rules, there's no one rule that I would recommend as ready for prime time just yet, but I think we have in the works some implementation studies planned to try to understand if these rules can be safely implemented into practice for kids who have clinically suspected pneumonia. So all of this evidence, particularly with regard to asthma and bronchiolitis, led to the Choosing Wisely campaign to make this recommendation to do not order chest radiographs in kids with uncomplicated asthma or bronchiolitis. And that is where quality improvement methods come in to help us decrease chest X-ray use. And so guidelines recommend against chest X-ray, very low rates of pneumonia in kids with asthma and bronchiolitis. How do we actually change practice? So by now, I'm sure that everyone on this call, I'm preaching to the choir here, is familiar with achievable benchmarks of care. And there were 3 studies that were published, one by you all and Medic most recently, that looked at what are the median baseline rates, proportions of chest X-ray use in asthma, bronchiolitis, and croup in the inpatient setting, in the ED, and the medic data is there in the third column. And you can see in parentheses the achievable benchmarks for these things based on the inpatient achievable benchmark is 25% for asthma, 32% for bronchiolitis. I still think that's quite high. In the ED work that Dr. Jane Knapp performed, Dr. Knapp was one of the first fellows in pediatric emergency medicine when the fellowship first started. Her study found that asthma and bronchiolitis should have about a 17% achievable benchmark, and croup really should be 2%. I mean, there's no reason we should be getting chest X-rays in croup. Airway X-rays maybe for complicated or croup of uncertain etiology, and even then we really shouldn't be getting airway X-rays in the vast majority of kids with croup. And then this was data that you all published in 2020, looking at your baseline data, which when you look at this, it's very similar to the inpatient data, in terms of your median baseline rates of X-rays. And then the achievable benchmark, at least as I understood it, was a combined benchmark of care for these three conditions overall of 18.5%, which is consistent, I think, with Dr. Knapp's benchmarks that she set back in 2010, a decade earlier. So this study was done in Wisconsin and used quality improvement methods to decrease chest X-ray in outpatient pneumonia. There were three key interventions. The first was local guideline development and implementation. The second was provider feedback regarding testing. And the third was annual re-education. So, quality improvement, this was published in 2018. The actual project happened in the early 2010s. Quality improvement methodology has evolved greatly since the time that this was done, right? These are fairly low fidelity interventions that were done at this institution. But regardless, there was a pretty substantial effect in decreasing chest X-rays for kids seen in the ED, treat and release patients, kids that were discharged home. Their rate went from 70, when we look at the P chart, went from 79.3% down to, after special cause variation, to 57.3%, and that was maintained over a 22-month period. So impressive work, low fidelity interventions, single center. Not sure that this would work on a bigger scale, just with these low fidelity interventions. In the asthma world, this group at Vanderbilt, of hospitals at Vanderbilt, used quality improvement methods to decrease chest X-rays in asthma. And what you can see in their key driver diagram, their smart aim was they wanted to decrease chest X-rays from 29.3%, their baseline, down to less than 20%, so an achievable benchmark of care. Their key drivers were standardization of treatment, electronic ordering infrastructure, and educational review. So again, 1 and 3 are pretty low fidelity. 2 is starting to, be a higher reliability intervention, where you were doing things like removing chest X-rays from the default asthma, order set, removing wheeze as an indication from the chest X-ray. But a lot of these other interventions are things like create a clinical practice guideline and educate people. So what this study found, interestingly enough, I'm sorry, this is a little blurry, is that just publishing a CPG did very little. I mean, it shifted the baseline slightly, but it sort of did very little. But when the order sets were changed and there was order set updates and some further education, and the electronic ordering system was changed to match the revised CPG, they were able to make a change in the baseline in this P chart from an original baseline of 29.3% to 16% overall, which is below the achievable benchmark of care. So they did a great job in this intervention, and they used pneumonia as a balancing measure. And in this P chart, you can see that here's where the reduction in chest X-rays associated with interventions occurred. The baseline did not change. There was no increase in pneumonia when all of a sudden providers stopped doing chest X-rays. So what this group and others have used is sort of these 3 Institute for Healthcare Improvement levels of reliability performance. And forgive me if you know about these already, but I think it's worth talking about because they talk about reliability. IHI talks about reliability as the number of actions that achieve an intended result divided by the total number of actions taken. And what you can think about, the way that they frame this is they think about this in terms of failure rates. So it's 1 minus reliability. So 10 to the minus 1 means that there's 1 defect per 10 attempts. 10 to the minus 2 is 1 defect per 100. 10 to the minus 3, 1 defect per 1,000, for example. So this is really level 1, level 2, and level 3 reliability. And to achieve a level 1 reliability, a 1 in 10 failure rate, there's really no articulated common practice. The emphasis is on training and reminders. The goal is just preventing failure. And the types of interventions are things like standardization, education, and memory aids. And so these are really low reliability interventions, similar to what we saw in the pneumonia and the asthma QI projects that I just mentioned. To achieve a level 2 reliability, so 1 in 100 failures, this really requires intentionally designed tools and concepts that use human factors engineering. So the goal is to identify and mitigate failure. It's about error-proofing systems. It's about changing the order set to try to prevent people from ordering things that they should not order or making errors that they should. And then level 3 reliability is really process redesign. It's failure modes and effects analysis, right? So this is about, you want a well-designed system overall where the whole process and system is redesigned, and the relationship of that system to outcome is examined. So the same group in Vanderbilt learned a lot from their asthma work and did something similar with bronchiolitis, but used these IHI levels of reliability to try to frame their interventions. So here they wanted to reduce their bronchiolitis chest X-ray ordering from 42% to less than 15%. And their key drivers were a standardized approach, but they started looking at some increased reliability interventions, especially in their computerized physician's order entry system, standardizing an approach to bronchiolitis. So updated order set, implement a BPA when unnecessary therapies are ordered, this sort of thing. And what they found, interestingly, the low reliability interventions are in the blue boxes, and the higher reliability interventions are in the red boxes. So here was their baseline rate in this P chart of 42%. They did a bunch of low reliability things. They made a new CPG. They educated people. The AAP guidelines were published. And what you can appreciate is none of these low reliability interventions did anything to their baseline chest X-ray rate. But then they introduced a 10 to the minus 2 or a level 2 reliability feature where they changed the default order set, and they were able to lower their baseline after special cause variation to 23.3%. There were some more educational campaigns that didn't really do anything, but then there were these higher reliability interventions of updated order sets, changing the physician order entry that took that baseline even lower to 18.9%. Where they've maintained that. They still haven't reached their goal, but they are within the range of achievable benchmarks of care. So some pretty impressive work. And you can see this is the discharged patients from the ED. Again, the higher reliability interventions made a bigger difference in decreasing their chest X-ray use. And here was their inpatient chest X-ray use coming down, by 50% from 60% to 35%. So now that we've discussed sort of what people have done to try to intervene to lower chest X-ray use for these things, let's talk a little bit about the opportunities that exist. How can we use this knowledge and data to improve care? And you're all familiar with this. This is your own clinical considerations for chest X-ray in kids with a history exam consistent with asthma, bronchiolitis, or croup. And if none of the below are present, question your reason for chest X-ray, which I think is reasonable. I did not talk about comorbidities. Most of these studies occurred in previously healthy kids. So clearly kids that are at increased risk of pneumonia because they have cystic fibrosis, they have a trach, or they're at risk of encapsulated organisms like kids with sickle cell. These kids, this is not the target population that we're trying to really decrease utilization substantially. What we're really trying to make a difference on are those kids that have routine asthma, bronchiolitis, and croup, who really have such a low risk of a pneumonia that, and the data that I've showed you, both the evidence and the quality improvement data, I hope showed you that, there was no increase in revisits in pneumonia when these things were looked at as balancing measures in any of this work. And that's the population that we really want to focus on. The one thing I might add to this would be oxygen saturation, as I've showed you sort of in the evidence portion of this talk. But in general, this is a pretty good tool to use to sort of stop and think, do I really need a chest X-ray in these kids with asthma, bronchiolitis, or croup? And thanks to Andy and the team for sharing your data on chest X-ray use for asthma, bronchiolitis, and croup. This top graph shows you your utilization over time. And the good news is the median utilization, you did awesome work, decreased from 40% at baseline down to 20%. The challenge here is that you could see that the spread from lowest utilizing site to highest utilizing site has increased. That's likely due to the fact that more hospitals started to contribute data after 2019, but keeping an eye on that spread is important. And I think what the 2022 data shows us from your collaborative is that really that increase is due to a few of these outliers up here. What I do want you to appreciate from this graph at the bottom is that the red line is really your achievable benchmark of care, about 18%. And, about almost a third, a quarter to a third of hospitals are actually below that line, which is awesome. The dashed line is if we think about the range of achievable benchmark of care, so maybe the upper limit of achievable benchmarks of care. And you can see that most of your institutions, actually 2/3 about, fall below that upper limit line. And there are opportunities in this upper third to try to make some changes that can help decrease chest X-ray use. So what are some things that can be done? So hopefully from this talk, you've taken away that we can move from these 10 to the -1 to the 10 to the -3 interventions, making structural changes to order sets, ensuring that options do not exist for people to choose, or that pre-checked options don't exist. So making systems-based changes that will change behavior. I think Nudges at the Point of Care, Nudge is a great book to read if you haven't read it already, but Nudges at the Point of Care have been shown to change physician behavior, and there's mixed data on whether audit and feedback and provider report cards actually change behavior. But I think this idea of moving from a low reliability to a higher reliability intervention has shown success, as I've shared with you. I think we need to collaborate with our radiologists. We need to work with our radiologists to try to standardize their reporting. It's an imperfect test, we get that, but I've had success when I've spoken with radiologists at certain institutions. I know at Cincinnati Children's, they've done a lot of work at really standardized reporting, and they try to avoid some of these ambiguous reports that put the bedside clinicians in a bit of a bind, even with an imperfect test. I think we will have the opportunity soon in the future to integrate evidence-based risk calculators for pneumonia and other more serious things that can help us to actually then not only use our gestalt, but then have an individual risk prediction for that child in terms of their risk of going on to develop pneumonia. I think we need to do more shared decision-making with families and explaining the pros and the cons, of the decisions that we make in this. And then the last thing I would leave is really sort of any other ideas, because really the most successful ideas for making this work are going to come from you. The people who are, the champions who are leading this at the site level, working with clinicians, nurses, the healthcare team, knowing your institutional policies, your institutional culture, knowing your patients. These are where the best ideas come from. And so with that, I will stop. I appreciate your attention. I'm grateful for the invitation to come share some time with you today. And I'm happy to take any questions or have some discussion at this time. I'm going to actually stop sharing so I can see everyone as well.
Thank you, Dr. Florin. Amazing talk. And I thank you for getting so granular. And we agree on so many points that you've raised here. I just want to remind everybody on the call, please feel free to put your questions in the chat. This is the time we have with our expert, and let's use it. I'm going to kick it off with just a couple of thoughts. I think, MEDIC is built on what the ED clinician can control to make a quick decision. And as you pointed out, it's an amorphous group of clinical presentations, and that's what you're left with. One of the things that I've noticed in your work, in your publications, and even in your discussion today is this notion about fever and hypoxia. And in the ED, of course, fever comes in different flavors. Of course, fever at the triage, no fever because somebody gave the kid rightfully some Motrin or Tylenol, but a history of fever, how reliable is that? And how long have you actually had a fever? So it just kind of, and that's why we really, have, fever as part of our toolkit. But is there a more or a better way to talk about fever as a risk potentially in your prediction models as you begin to think about those? I noticed that some of them had 5 days, with a, likelihood ratio was higher, and that makes sense. But what about that other interval, like 24 hours, 72 hours, something like that? Is there any merit to that?
So, I think, Michelle, we all know, right, that duration of fever is sometimes in the eye of the beholder, right? And so it's very hard to actually nail that number down, in an accurate sense. What our prediction rule showed, the one that we did, and that Sriram did, out with using our data from Cincinnati, we did find that the threshold for duration of fever was really, you started to see that increased risk at 3 to 5 days. And in terms of height of fever, there was an increasing, the higher the fever, the more likely, but really the 39 and above was really sort of a threshold. And if you think about it, for all the clinicians, on the line, on the call, most kids with bronchiolitis are not going to actually have that really high fever combined with hypoxemia. Like that combination is pretty, is not as common as fever alone. And most of these kids are in that 38 to 39 range. We still did see increased risk. I'm not saying that we shouldn't think about it in that 38 to 39 degree range, but really we do see the risk really climb above 39 and above more than 3 to 5 days of fever. I do think, though, that fever alone is a really dangerous thing for us to use in isolation. And when you actually look at the meta-analyses, I didn't share data from Dr. Sonal Shah's meta-analysis in JAMA, which is great, and everyone should look at it, which basically looked at individual signs and symptoms and likelihood ratios for predicting pneumonia. And fever had a likelihood ratio of 1. I mean, it did not in isolation predict pneumonia. But when we combine fever with hypoxemia, I think that becomes a powerful combination. And actually, in the adult literature, there are some folks that have published studies in the adult literature that basically say if you're not hypoxic, if your saturation is not less than 95 to 96%, you don't have bacterial pneumonia. And so that's a little bit provocative, the studies that have published that, but I would say that our work kind of, proves that to be true as well. I think if you don't have fever and hypoxia together, the likelihood of you having pneumonia is pretty low.
Thanks. I have one other, maybe sort of quick question. You know the landscape of kind of who is doing what, and it was refreshing to see that the hardwire intervention tactics seem to make a huge difference in actual behavior change. And understanding that most of us on this call don't have sometimes the power to go to get your electronic health record changed. How can we do that more effectively to get that kind of hardwired into our systems? Because I agree with it. I think that once you sort of take away abilities or change your abilities electronically, it does prevent some of this stuff. But how does that get done when you really don't have control over it?
That's a great question, Dr. Nypaver. So I think, I think all of us have worked with our hospital IT and our hospital Epic or Cerner teams, and it's always such a positive, collaboration. It's really challenging, and I think unfortunately the reality is, all joking aside, is that these teams have huge numbers of priority lists. That their priority list is incredibly long. And getting your initiative on that list is oftentimes very difficult. So I think that they have a difficult job trying to prioritize every priority that comes their way. I do think that systems based. If you actually look at the data, that changing the way that clinicians order is going to be some of the strongest data for behavior change, in terms of the orders that are available to the docs and the APNs, PAs at the bedside. But if you can't do that, then I think it becomes, there are some lower fidelity things that have been successful. So before electronic health records were in place, in the antimicrobial stewardship world, they did a lot on posters and educational campaigns and, posting at the computers like, do you have a kid with asthma, bronchiolitis, or croup? Pause before, does this child really need an x-ray? That's a poster at sort of the computer. It's low fidelity. It's not going to be as good as a systems-based change, but it's something that can be done that you might have control over. I think, what I try to teach my residents and fellows, before they order any test, is to just take a 30-second pause to ask what they're going to do with the results. And I think that's one of the best things that we as humans, can do in terms of behavior, is before any test ordering, chest x-ray or otherwise, to just sort of pause for 30 seconds, even in a busy ED workflow, and think about, what am I going to end up doing with the results here, rather than reflexive testing, where, okay, kid has fever, respiratory symptoms, I'm just ordering, I'm ordering the CBC, which has no utility in kids with respiratory disease, by the way. I'm just going to order the CBC blood culture and chest x-ray and be done with it. And I hope I've convinced you with that has repercussions that are bigger than the 30 seconds that we could take to pause as clinicians and say, like, do I really need this? Like, does this kid really at risk for pneumonia, or am I just doing this to, help alleviate my own anxieties or my own medical legal concerns, whatever the case may be.
I'm going to get off the podium and just make sure our audience doesn't have questions, or other people in our coordinating center can pick your brain. Anybody else?
That was a great talk. Thank you so much. I know we're at time, but I just wanted to ask if you had a pearl or a strategy when you're discussing getting the chest x-ray with families who are kind of hell-bent on coming into the ER for their chest x-ray.
So, that's a great point. And I think I would expand what I'm about to say to antibiotics as well. I think that we as clinicians think that families want more than they actually do in a lot of cases. Now, that there are definitely families, we've all taken care of them, that come in and they say, I'm not leaving this ED until I get a chest x-ray. And so, but for the most part, we as clinicians, we make a lot of assumptions, especially in the antibiotic world. The literature is clear, especially now in the last 5 years, parents do not want to be giving their kids medications that they do not need. Maybe 10 years ago, that was more the case, but as social media and technology and information dissemination, for better or for worse, there's the disinformation and the misinformation, which we won't get into. But I think parents have become a little bit more savvy about testing and treatment for their kids. So I think, many of us in the ED, we work in a very busy environment. We don't have a lot of time, but I think spending, 3 to 5 minutes explaining, there have been studies that have been done. I'm listening to your kid. I don't hear anything that I'm worried about when I listen with my stethoscope. Look, their oxygen level is, 98%, and their, respiratory rate is square in where it needs to be. And, the likelihood of this being a pneumonia is really, really low. And we wouldn't want to, expose your child to radiation, add cost, find, things that are non-specific that may lead to other things. And, as a result, we don't want to give your child, testing or expose your child to unnecessary, potential harm if we don't have to. And, that framing is what I actually use when I talk about antibiotics with families and with clinicians for that matter, is that every single time that we give an antibiotic to a child who doesn't need it, we are introducing harm to that patient. I hope in the collateral damage slide that I've gotten that across, ad nauseum. But we oftentimes sort of poo-poo these things. It's just amoxicillin. But the reality is if that child doesn't need amoxicillin, then we are doing something to that child that is introducing potential harm. The harm might be low, might be mild, but the harm may also have longer term consequences. And I just think this is the sort of thing that we just have to pause at the bedside to think about, and that we shouldn't be afraid to actually talk through our thought process with our patients a little bit about, because I think they every time I do it, the parent is appreciative of hearing that thought process out loud. And it doesn't take me that long.
Thanks, Todd. Terrific question to end on.
Well, I just want to say this was really great. I really appreciate the time spent with you all. I've appreciated, over the last few months learning about the great work that you all are doing, and I hope I'm happy. I hope that we have the ability to collaborate, in the future. I just think what you're doing is so outstanding and so important, and I would welcome being a part of it. If it works out. Thank you all.
Thank you. It's an amazing talk.